Hello students, today we are going to discuss pharmacology of drugs used in the treatment of congestive heart failure. Now as we all know, congestive heart failure is the failure of heart to pump sufficient amount of blood to fulfill the metabolic demands of body tissues and organs. That means the pumping efficiency of heart is reduced in congestive heart failure. There is reduced pumping efficiency, and because of the reduced pumping efficiency, there is reduced cardiac output. And this reduced cardiac output, because of this reduced cardiac output, sufficient amount of blood is not available to the body tissues and to the body organs. And this further results in triggering of compensatory mechanisms. There is activation of compensatory mechanisms in order to increase the cardiac output. Now these compensatory mechanisms increase the cardiac output initially, but over a period of time there is further fall in the cardiac output, there is further worsening of congestive heart failure, and the heart failure is termed as to be the decompensated heart failure. Now when we talk about the stimulation of compensatory mechanism, each compensatory mechanism comes at a cost, and which further worsens the heart failure, which further worsens or which further reduces the cardiac output. Now first compensatory mechanism, or the most important compensatory mechanism, is the sympathetic stimulation. There is a sympathetic stimulation. Because of the sympathetic stimulation, initially there is increase in the heart rate, and because of the increase in the heart rate, there is increase in the cardiac output. But on the other hand, because of sympathetic stimulation, there is increase in the peripheral resistance. That is, lumen of the blood vessels is reduced. Increase in the peripheral resistance is termed as to be the afterload. So because of the increase in peripheral resistance, the load on the heart increases. That is, the afterload on the heart increases. There is narrowing of the blood vessels or constriction of the blood vessels. There is constriction of aorta as well. Aorta is the largest artery of the body, and the left ventricle directly pumps the blood into the aorta. So there is narrowing of the lumen of aorta, and because of the narrowing of the lumen of aorta, there is increased resistance to ventricular pumping. Now the heart has to work even harder to pump the blood into constricted aorta, and this results in the left ventricular hypertrophy. This results in the ventricular remodeling, and ventricular remodeling further reduces the pumping efficiency of the heart. So initially sympathetic stimulation is increasing the heart rate and increasing the cardiac output, but over a period of time it results in left ventricular remodeling. Now one category of drugs are the beta blockers. Now beta blockers antagonize pathological remodeling, and this pathological remodeling due to excess sympathetic activity. And these drugs, they provide not only symptomatic relief, but these beta blockers, they also arrest left ventricular hypertrophy, that is the left ventricular remodeling. Now another thing is this, that because of the sympathetic stimulation, there is activation of renin-angiotensin-aldosterone system. And because of the activation of renin-angiotensin-aldosterone system, there is increased synthesis of angiotensin 2. And angiotensin 2, we know, is a potent vasoconstrictor on one hand, and on the other hand it stimulates the release of aldosterone. So angiotensin 2, because of the activation of renin-angiotensin-aldosterone system, there is increased synthesis of angiotensin 2. Angiotensin 2 is a direct vasoconstrictor. It constricts the blood vessels, it increases the peripheral resistance. Over a period of time, it results in the left ventricular hypertrophy. On the other hand, because of the increased production of aldosterone, increases the reabsorption of sodium and water. Because of the reabsorption of sodium and water, there is volume expansion, the blood volume increases. So initially, increase in the blood volume increases the cardiac output, but over a period of time, it results in the venous congestion. It results in the accumulation of blood in the venous system. and further it results into pulmonary edema and systemic edema. So because of the venous congestion, there is a increase in the preload, that is and again the load on the heart increases, and over a period of time this volume expansion results in the ventricular dilation, and again because of the ventricular dilation there is reduced cardiac output, and again there is further worsening of the heart. Now we have a category of drugs, a very important category of drugs termed as to be the ACE inhibitors, that is the angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers. Now these drugs, that is the ACE inhibitors and angiotensin 2 receptor blockers, these are the mainstay of treatment of congestive heart failure, as these are the drugs which provide not only symptomatic relief, but these drugs, they also regress or they also retard the progression of disease. They prolong the survival by retarding the left ventricular remodeling. Another category of drugs are the aldosterone antagonists, that is the spironolactone. Spironolactone, it antagonizes all the effects of aldosterone, and it reduces the preload, and it is also found to be useful in the management of congestive heart failure. Another category of drugs are the diuretics, loop diuretic like furosemide. Diuretics reduce the blood volume, thereby they reduce the preload, they reduce the load on the heart, they improve the ventricular efficiency by reducing the load on the heart, and they are also found to be useful in clearing the pulmonary congestion and systemic edema which is caused because of the congestive heart failure. Another important category of drugs are the venodilators, those drugs that dilate the veins, for example glyceryl trinitrate, and by dilating the veins they reduce the preload on the heart, they prevent the further ventricular dilation. And another type of dilators are the arteriolar dilators, for example hydralazine. And these arteriolar dilators, what they do is this, that they dilate the arteries, they reduce the peripheral resistance, and because of the reduction in the peripheral resistance they regress or they arrest the left ventricular remodeling. And there are certain drugs like sodium nitroprusside. Sodium nitroprusside not only dilates the veins but it also dilates the arteries, and it is found to be useful in reducing the preload as well as in reducing the afterload. Another important drug is the digitalis. Digitalis is an ionotropic agent. It increases the force of contraction of cardiac muscles, and by virtue of increasing the force of contraction of cardiac muscles, it improves the efficiency of heart and it increases the cardiac output. But the major drawback of digitalis is this, that the margin of safety is low, and apart from that digitalis is also proarrhythmic. So now we will study the pharmacology of each individual class in detail. Before discussing pharmacology of individual class of drugs, let's see the goal of treatment. Now the goals of treatment for the congestive heart failure are number one, and the most important is the improvement in symptoms, increase in the cardiac output or restoration of cardiac output. And the second important goal is the arrest or retardation of progression of disease, reduce mortality and increase the chances of survival. Now when we talk about the treatment, there are two approaches. One is the non-pharmacological approach, other is the pharmacological approach. Now under the non-pharmacological approach, the patient should be advised rest, because the rest reduces load on the heart. The intake of sodium should be restricted, and sodium intake should be less than 2 grams per day, and reduction in the sodium intake reduces the retention of water in the body. Then restriction in the water intake should not be more than 1.5 to 2 liters per day, and again restriction of water intake reduces edema, that is the pulmonary congestion and systemic edema in the body. And under the pharmacological approaches, there are two types of medications. First is the first line medication and another is the second line medication. First line medication include those drugs which improve the symptoms, and apart from improving the symptoms of CHF, these drugs also arrest progression of disease. They reduce the mortality, they increases the survival rate. Whereas the second line medications are the drugs which provide symptomatic relief, which improve the symptoms, but they do not provide mortality benefits. Now let's discuss pharmacology of first line drugs used for the treatment of congestive heart failure. The most important category of drugs are the renin-angiotensin system inhibitors. Under this category, we have angiotensin converting enzyme inhibitors like captopril, enalapril, lisinopril, and we have angiotensin receptor blockers like losartan, valsartan. And these drugs, they are the mainstay of treatment, because apart from controlling the symptoms, these drugs, they also improve the survival, they reduce the mortality, and they regress the left ventricular remodeling. So these drugs, they block the actions of angiotensin 2, and angiotensin 2 we know is a direct vasoconstrictor. So on one hand it increases the peripheral resistance, on one hand it increases the afterload, on the other hand it stimulates the production of aldosterone, which causes increased reabsorption of sodium and water, increasing the blood volume, which increases the preload. So these drugs, they block the action of angiotensin 2. Thereby they inhibit the vasoconstriction. Inhibition of vasoconstriction, that is vasodilation, increase in the lumen of the blood vessels, reduces the peripheral resistance, it reduces the load on heart, it reduces the afterload on the heart, thereby improving the efficiency of the ventricles. On the other hand, these drugs, they reduce the reabsorption of sodium and water. By reducing the reabsorption of sodium and water, they reduce the blood volume, and reduction in the blood volume reduces the venous congestion, reduces the pulmonary edema and systemic edema. There is reduction in the preload. So these drugs, they reduce preload as well as afterload. So these drugs, they reduce load on the heart, they increase the efficiency of ventricles. Apart from this, renin-angiotensin system inhibitors, they also increase the level of kinins, which stimulates generation of cardioprotective nitric oxide and prostaglandins. And these drugs are recommended for all grades of congestive heart failure. They are the mainstay of treatment of congestive heart failure. And these drugs, they are found to be very useful. They are always preferred in the treatment of CHF because these drugs retard or prevent ventricular hypertrophy. They prevent myocardial cell apoptosis. They prevent fibrosis, intracellular matrix changes. These drugs, they inhibit ventricular remodeling. These drugs arrest or reverse the progression of disease. They prolong the survival and they reduce the mortality. Another very important category of first line drugs are the vasodilators. As I have discussed before also, there are certain drugs like glyceryl trinitrates which dilate the veins, and they are termed as to be the venodilators. By dilating the veins, these drugs, they reduce the preload. Reduction in the preload results in reduced ventricular filling pressure, reduces the ventricular size, there is shortening of myocardial fibers, and overall there is improved ventricular efficacy, which results in increased ejection of blood, which increases the cardiac output. Then arteriolar dilators, those drugs which dilate the arteries. By the dilation of arteries, by increasing the lumen of arteries, there is reduction in the peripheral resistance, and because of the reduction in the peripheral resistance, there is reduction in the afterload. Now the heart has to do less work in pumping the blood into the aorta. So there is fall in the systemic vascular resistance that improves the functioning of the heart, that increases the ejection of blood, for example hydralazine, minoxidil, calcium channel blockers. And there are another type of drugs which dilate not only the arteries but also the veins. For example, sodium nitroprusside. This is the drug that reduces the preload as well as the afterload. But here when we talk about the vasodilators, glyceryl trinitrate, the drugs like glyceryl trinitrate, that is the nitrates, nitrate tolerance limits the utility or the use of these nitrates. If these nitrates are used regularly, they result in the nitrate tolerance. And drug hydralazine, it produces marked tachycardia. So marked tachycardia, worsening of myocardial ischemia and fluid retention limit the utility of hydralazine. And these drugs, they are used as alternative for patients who are intolerant to renin-angiotensin system inhibitors. Another category of drugs are the beta-adrenergic blocking drugs, beta blockers. And these drugs, apart from improving the symptoms, these also regress left ventricular remodeling, and they provide mortality benefits. Under the beta-adrenergic blockers, we have two subclasses: beta-1 blockers, for example, metoprolol, bisoprolol, nebivolol. And then we have non-selective beta and the selective alpha-1 blockers, for example, carvedilol. Now these drugs, they antagonize pathological remodeling effects of excess sympathetic activity, already we have seen. And these drugs, they are used as add-on therapy, they are used as an adjuvant as they retard the disease progression. Another very important category of drug, aldosterone antagonists, spironolactone. We have already seen the mechanism of action of spironolactone. Now, aldosterone causes increase in the blood volume by sodium and water retention, and increase in the blood volume increases the preload. And apart from that, it also causes fibroblastic proliferation, which is responsible for ventricular remodeling. It also causes hypokalemia, and it also reduces the level of magnesium in the blood, and therefore it is pro-arrhythmic. It increases the risk of arrhythmias. Now, aldosterone antagonists antagonize all the effects of aldosterone, and therefore they reduce the preload, they reduce the load on the heart, they improve the efficiency of ventricles. And on the other hand, by antagonizing all these effects of aldosterone, these drugs regress left ventricular remodeling, they increase the survival and they reduce the mortality. So after this first line drugs for CHF, let's discuss the use of second line drugs for the treatment of congestive heart failure. These are the drugs which provide symptomatic relief, but there are no mortality benefits. First drug is the ionotropic drug, that is the digoxin. Digoxin is a cardiotonic as it increases the force of contraction of cardiac muscles. Another drugs are the dobutamine or dopamine. Then we have ambrinon, milrinone. First, let's see the pharmacology of digoxin. It is a cardiotonic. It inhibits sodium potassium ATPase pump, and by virtue of inhibiting sodium potassium ATPase pump, it increases intracellular calcium concentration inside the normal contractile cardiomyocytes, and therefore more calcium is available when these cardiac cell contracts. It is most effective in congestive heart failure with dilated heart, and in congestive heart failure with a low ejection fraction. But however, the limitation of digoxin is its low margin of safety, and it is also pro-arrhythmic. It causes the depression of ST segment, it causes changes in the ECG. Another inotropic agent is the dobutamine. It is a beta-1 agonist. It is an inotropic, it shows inotropic action. IV infusion of dobutamine is used in acute heart failure, and it is also used in advanced decompensated heart failure. So, the use of dobutamine is restricted only for the short term use. Then another drug is the dopamine. It is a D1 agonist. It shows D1 agonistic action. It is used in the treatment of cardiogenic shock. and its benefits are short lasting, and on regular uses these drugs they produce tolerance and cardiotoxicity. Another drug is milrinone. It is a phosphodiesterase 3 inhibitor. It produces positive ionotropic effect, and it also causes vasodilation. Half-life of the drug is 40 to 80 minutes, and therefore it is restricted for the short use, and it is used in severe and refractory congestive heart failure. Another very important category of drugs are the diuretics. Diuretics are, we have already seen, we have already discussed, and these diuretics, they are the mainstay of treatment for the treatment of fluid congestive heart failure associated with the fluid accumulation. And a very important drug is the furosemide. It is a high ceiling diuretic and it is the drug of choice, but resistance develops to furosemide, and addition of potassium sparing diuretic like spironolactone overcomes resistance to furosemide. So furosemide is used along with the other diuretics like spironolactone. Now these diuretics, they reduce the volume of blood, and therefore they reduce the preload, they reduce accumulation of fluid, they clear pulmonary congestion and systemic edema, and further there is improvement in ventricular efficacy as the load on the heart is reduced. They remove peripheral edema and pulmonary congestion, and these drugs, these are not used as a sole drugs, but these drugs are added intermittently to the primary therapy for the symptomatic relief. So this is all about the drugs which are used for the management of congestive heart failure. Hope you must have enjoyed the session. Thanks for watching the video.